So looking further here at our baroreceptors, these are really pressure receptors. There are different types of baroreceptors, by the way. And so we'll talk about the ones that are on our arteries. The ones that are on our arteries are pressure receptors because they're detecting the amount of pressure of blood in those arteries. But then we also have some in our veins that I'll talk about later on that are more volume receptors. They're going to detect how much volume is existing in the veins. And so the pressure receptors are usually called stretch receptors. They're on our arteries again, so they're called arterial baroreceptors. And we've got two of them. There's one on the aortic arch. So if you remember our anatomy here, the arch of the aorta has some of those receptors, those pressure receptors or baroreceptors. And then we've also got some on our carotid sinuses. So there's a swelling right before the carotid arteries split off into internal and external carotids. And that swelling is where we have the carotid sinuses, right? And so these two stretch receptors are pretty much detecting how much pressure exists that's coming from the heart. And so we can see based upon their location, their strategic location, they're really picking up the pressure with which the blood that's leaving the heart is under. And so it's really doing so by stretch. It's responding to stretch. So if the blood in these vessels is under a lot of pressure, it's going to create more stretch on these structures. And then we're going to have an increase in firing frequency on the nervous tissue in these areas. And if there is low pressure in these vessels, we're going to have the opposite. It's going to decrease in stretch and therefore decrease the firing frequency of the nervous tissue in these areas. Okay. The second player here, those integrating centers, so usually the medulla oblongata. And so the medulla oblongata is going to pick up information that's coming in from those baroreceptors about what the pressure looks like in the vasculature. And it's going to basically make decisions about corrective measures that would be communicated on the autonomic nervous system. Okay, so it's basically the integrating center where those signals are sent from baroreceptors and pretty much analyzed, and then the relative changes are determined by these cardiovascular centers. And then the output signals are sent by the autonomic nervous system to our cardiovascular effector organs. So again, this is going to be the blood vessels and the heart itself. Now we want to remember here from our prior knowledge that the parasympathetic system only has an input on the SA node and the AV node. So it only works to decrease the heart rate. It has no influence on ventricular contractility. It has no influence on arterioles. It has no influence on veins, okay? It only will correct these changes by manipulating the heart rate, specifically decreasing the heart rate. The sympathetic system has a more invasive response or a more extensive response in terms of regulating that mean arterial pressure. So the sympathetic nervous system can increase heart rate via inputs to the SA and the AV node. It can also increase ventricular contractility by forcing those contractile cells of the myocardium to work harder. It can also increase our arterial resistance by influencing the state of our smooth muscles on arterioles. So we talked about this, the fact that the sympathetic nervous system via norepinephrine and alpha adrenergic receptors creates that contraction of smooth muscle, which increases resistance in arterioles. And that would too increase mean arterial pressure. And then it can also have an input on veins. So that small strip of smooth muscle that lines the internal surface of veins is also under the influence of norepinephrine binding to alpha adrenergic receptors and creating that decreased compliance, which we call venomotor tone. So the sympathetic nervous system plays a more involved, a more extensive role in regulating mean arterial pressure, whereas the parasympathetic nervous system really only manipulates the SA and AV node, which is only influencing the heart rate. Okay. All right, so that just kind of is illustrated on this slide. We see the parasympathetic division here coming from the brainstem, specifically the medulla oblongata, where we have those cardiovascular control centers, and sending its signal only to SA and AV node, okay? Whereas the parasympathetic system, again, there should be a review, right, coming through the thoracolumbar segments of the spinal cord, going out to synapse onto the sympathetic chain temporarily, and then eventually synapsing on to the SA and AV node, as well as the contractile cells of the myocardium, as well as our arterioles, right? Arterioles creating that increased total peripheral resistance, and then also our veins increasing that venomotor tone, okay? So as you can see, the sympathetic system has more of a role to play in regulating that mean arterial pressure. All right. So I'm going to pause here again, and then we're going to look at this flow chart that kind of summarizes all that we've just said and shows how mean arterial pressure is regulated by regulating our three important variables. So heart rate, stroke volume, and total peripheral resistance. And remember, this is a directly proportional relationship. So if I increase heart rate, I increase mean arterial pressure. If I increase stroke volume, I increase mean arterial pressure. If I increase total peripheral resistance, I increase mean arterial pressure. And so if I'm in the face of some type of vascular injury, some type of bleeding, some type of hemorrhage, anything that would cause my mean arterial pressure to drop below normal, which we described as being more imminently dangerous, what I'm going to want to do as a corrective mechanism is increase my heart rate, increase my stroke volume, increase my total peripheral resistance as a way to increase my mean arterial pressure, okay, and help with that perfusion. Okay. So again, we want to think about this drop in mean arterial pressure. So in your mind, thinking about someone who's hemorrhaging, who's dehydrated. And so the first thing the body wants to do is it's going to pick up those changes. It's going to pick up that drop in blood pressure via those arterial baroreceptors. So again, looking at our carotid sinus, looking at our aortic arch, those baroreceptors would detect that there's lower pressure than normal because of that bleeding or that dehydration or whatever, okay? The next thing that happens is, the autonomic nervous system via the instruction from the integrating centers, right, the cardiovascular centers in the medulla oblongata, the autonomic nervous system is going to respond here. It's going to decrease sympathetic activity for a start, but then remember, we talked about this dual secrecy here. The fact that decreasing parasympathetic is not enough. We also need to increase sympathetic on the other hand, okay? But first we're going to decrease parasympathetic. That is going to increase the firing action potential rate on our SA node. And I really want you to understand this relationship, that if we decrease this parasympathetic influence to the SA node, then the sympathetic will kind of outweigh here. And that is where we get that increase in the SA node firing rate, okay? That is going to increase how fast our SA nodal cells are working, the heart rate, and that is going to also help to increase our mean arterial pressure. The second thing we want to do is increase sympathetic activity. Again, that dual secrecy, the fact that we must tone down parasympathetic, but also tone up sympathetic in order to bring about that response. And so increasing our sympathetic activity has a few other factors that it influences as well. It will increase our heart rate. It will also increase how hard those contractile cells are working, increase that ventricular contractility. So the contractile cells are, working much harder here. And I'm not gonna, kind of belabor this point, but if we think about those mechanisms within our contractile cells, right, increasing how much calcium comes into the cell, increasing the relaxation rate of our myocardial cells, all of those factors work to increase the contractility. The next factor that we're going to look at Right, so all of those factors increase ventricular contractility, which increases stroke volume, how much blood is ejected from the heart. The next factor that we'll look at here is the veins. Remember, the sympathetic system also influences the veins. It's going to increase that venomotor tone. It's going to cause the smooth muscle there to constrict or contract, and that will put more pressure on the blood, increasing that venous return. So increasing venomotor tone, it decreases the compliance of our veins, increases the venous pressure in our veins, and helps with that venous return. Remember, in order for the heart to eject more blood, it must fill more blood first, okay? And so if I increase my end diastolic volume via this venomotor tone mechanism, then I will basically increase my stroke volume, right? The heart can fill more blood, and so it can now eject more blood, okay? And then the fourth factor here is the influence that the sympathetic nervous system has on our arterioles. So again, thinking about that norepinephrine with alpha adrenergic receptors causing vasoconstriction. And I want to kind of put a caveat here because we talked about the fact that the brain is exempt here, right? So we're going to cause vasoconstriction on most tissues except the brain and except our heart and muscle here. Okay, so you want to be thinking about some of those exceptions. So if I cause that vasoconstriction, that is going to basically cause more total peripheral resistance as the smooth muscle in those arterioles constricts or contracts. And so remember, TPR is one of our variables. If I increase TPR, I'm then going to increase my total peripheral resistance, okay? So what this really highlights is how we can correct mean arterial pressure, which is our initial error signal, really, and we do so by increasing total peripheral resistance, increasing stroke volume, increasing heart rate, which all work to increase mean arterial pressure and help to correct that initial drop in mean arterial pressure, okay? All right, I'm going to pause. Oops, lost my stylus. I'm going to pause here and see what questions we have about this so far. Okay. Now I want to put in two disclaimers here. The first disclaimer is that when the sympathetic nervous system acts to increase vasoconstriction in our arterioles, we would kind of think, well, gee, isn't this going to cause, hypoxia in all of our other tissues? And so we want to think about those intrinsic mechanisms in our local tissues. So while we have a systemic or an extrinsic input that is creating vasoconstriction to arterioles and kind of sacrificing blood in most of our tissues for the sake of our heart and muscles, we want to remember that there are still intrinsic mechanisms. So as those local metabolites, those local factors build up in some of those tissues, think about carbon dioxide, think about acid, think about potassium. As those things build up in those tissues, we will also see vasodilation to some degree. So there's a little bit of vasodilation being created as a regulatory response from the intrinsic mechanisms happening in the local tissues. And so that intrinsic mechanisms really is helping to protect those other tissues that are otherwise being, having their blood flow sacrificed for the sake of keeping perfusion to our heart and muscle. So we don't completely cause hypoxia in our other tissues. We still have those intrinsic mechanisms in the background that are kind of balancing out this vasoconstriction and helping to maintain flow and preventing hypoxia in those tissues as well, okay? The other disclaimer that I want to point out is the fact that our baroreceptors are kind of detecting pressure and working to correct that pressure via these three mechanisms at the bottom here. But this is not the end all be all, right? We do have a way to override this baroreceptor response. And a really good example of this is if you think about someone who has chronically sustained high blood pressure. So after a while, what happens is the baroreceptors kind of dial in a new set point and they kind of blunt this response. And this is why blood pressure is so dangerous when it's sustained high, because you blunt your body's natural response to correcting high blood pressure. And so you dial in a new normal. So your body thinks that a blood pressure of maybe 200 is now normal. And then that becomes detrimental because it works to maintain that new normal. Okay. So the baroreceptors response can be overridden if there is this long-term sustained incorrection or of this mechanism, if that makes sense. Okay. All right. So let's keep going here. So again, this is a negative feedback response. So when we increase our mean arterial pressure at the bottom here, we simply turn off this error signal as our mean arterial pressure gets back to normal. Okay. And so here we're going to look at some of those long-term factors. So basically where the hormones come into play. Now, the baroreceptor reflex kind of compensates in a quick mechanism for our blood pressure, but it doesn't necessarily correct the problem. It just kind of compensates immediately. And so our long-term mechanisms like increasing our blood volume through the kidneys is more of a corrective mechanism to the underlying problem. Okay, so I'll say that again. Things like our baroreceptor reflex is basically kind of putting a Band-Aid on the initial problem. Right? If we don't have enough blood in our vasculature, that's going to create an immediate reflex or an immediate response. But in order to correct that, that's going to take a bit more time. And so the kidneys will come in here in more of a long-term role and increase our blood volume by holding on to more water in the kidneys, and that will actually fix the problem instead of just kind of compensating for it temporarily. And so the hormones that play a role in that long-term regulation are epinephrine, vasopressin, which is also called ADH or antidiuretic hormone, as well as angiotensin II, some of our hormones that act on our kidneys. And so epinephrine is going to increase mean arterial pressure. So it's going to act on the smooth muscle of our arterioles. It's going to help increase that total peripheral resistance, which we just talked about. It's also going to act on our smooth muscle in the veins, which is going to increase that venomotor tone, again, sort of decreasing the compliance of veins. And then it's also acting on the heart, both the heart rate via the SA and AV nodal cells, as well as stroke volume via the contractility of the heart as well, okay? And then the hormones here, vasopressin and angiotensin II, these are going to cause vasoconstriction. That's going to increase total peripheral resistance, which we know will increase mean arterial pressure. And we'll talk about the mechanisms of these hormones a little bit later on, but also in the kidneys where we look at how they influence that long-term regulation of blood volume. Okay. I'm going to pause here again and see what questions we have so far. All right. So here we're looking at baroreceptors that are on our veins at this point. So these are more the venous baroreceptors. And so these are really described as being low pressure or pressure receptors, or sometimes volume receptors. And I talked about the baroreceptors on our arteries or our arterial baroreceptors being referred to as stretch receptors or pressure receptors, whereas the baroreceptors here on our veins are more determining what does the volume look like. Remember, veins are volume reservoirs. And so the receptors here on veins are really determining if there's low pressure, in other words, not enough volume in the veins, okay? So these are on the walls of our large systemic veins. So think superior vena cava, think inferior vena cava. They're also on the walls of our atria. So think about those receiving chambers where those veins are communicating to. And they are going to detect if there's not enough volume coming in these structures and these areas. And so if there's low blood volume, they're going to respond by acting in a reflexive manner in order to correct that blood volume initial